So friends, we by right heart catheterization, we can get the right-sided pressures. We know we can get RA pressure, RV pressure, pulmonary artery pressure, and pulmonary artery end diastolic pressure, wedge pressure, and we can get these pressures. But of course, in our clinical practice, we do require to get these pressures, at least the pressures by non-invasive methods, and which, in a case, we had to repeat them. And in that, we are discussing why right atrial pressure is important. Okay, earlier, if you know, in the ICUs also, we used to look at, states of cardiac failure and shock, and this was used very commonly. We used to estimate RA pressure, and you would decide whether the patient is volume responsive. Of course, these days, different methods are used. They actually see the volume responsiveness, fluid responsiveness by doing some other test, passive leg raising test, pressure pulse variability, and so on. Right ventricular diastolic properties we were earlier discussing. High right atrial pressure, of course, will be helpful there. In tricuspid stenosis, of course, the RA pressure will be high. But most important application of this RA pressure will be in presence of tricuspid regurgitation, which we require to get RV systolic pressure, which we get by TR pressure gradient, and adding to that right atrial pressure gives us pulmonary artery pressure in absence of pulmonary stenosis. And this is the most commonly used application in our clinical practice. And additionally, diagnosis as well as prognosis of pulmonary hypertension, we use this method. Now, tricuspid stenosis, we don't really have to find out RA pressure. For severity, we already know that, by gradients and by RV inflow VTI, with pressure half time and valve area by continuity equation, we can estimate severity of tricuspid stenosis. So we don't need to really know by our echocardiography absolute pressure of right atrium. So we know how we do that also. So, okay. Now, in presence of TR, for knowing pulmonary hypertension, now this is very useful. So, by TR jet, we can get, the gradient across the tricuspid valve. Okay. What we require now is additional right atrial pressure. Apart from that right atrial pressure also helps us for knowing the prognosis of pulmonary hypertension, because in this particular paper, it is very clearly mentioned that for different RA pressures, 0 to 5, 6 to 10, 10 to 15 and above 15, the outcome of pulmonary hypertension patients, is decided, because surviving patients, if you see survival drops, if the pulmonary RA pressure is higher in pulmonary hypertension. Now, earlier, for every patient, we used to assume that RA pressure is 10. And we know that that is not right. RA pressure will be different in different cases. And by echocardiography, we actually take this into account that RA events will be reflected in the attached veins. Okay, so the most commonly method that we use is IVC, diameter, and collapse of IVC during inspiration, because we know when during inspiration there is negative intrathoracic pressure, IVC is expected to collapse, or its absence, of course, if the IVC is dilated and it is not collapsing. So it helps us for diagnosis of raised RA pressure. What should be the exact procedure? What should we do? It should be done in supine. Subcost view should be used. We should take long axis of the IVC, not the short axis, and open the IVC well so that the diameter is its maximum diameter in the entire length of IVC that we are seeing. And we should look at IVC emptying into right atrium. So RA IVC junction we should see. However, we should not be measuring IVC at the junction, because at IVC junction, the degree of collapse during inspiration is less. And so there we should not be taking the measurement. Measure the diameter 1 to 2 centimeters away from the right atrium, and we should take inner to inner edge, and we should measure perpendicular to the length of the vessel. See, for example, now we see in 2D echo, we see IVC well, we should see it well. And we see that, okay, it is not collapsing. However, friends, just by doing this, now I was just saying that this measurement we have to see that not at the junction, but about 1 to 2 centimeters away from it, and there we should measure inner diameter, inner border to inner border. Like this, we should measure it. Okay, and for that we have to optimize the picture well. We have to remove the artifacts well. Now, for collapsibility, we had to not depend on the quiet respiration, but we should ask the patient for a sniff. Now, with sniff, what happens is that means in short time, the patient takes a short deep breath, and with that, there is sudden decrease in the intrathoracic pressure, and the IVC will collapse quickly, and that's what we should see. The commonly thing that I do in the room when I am doing the patient's echocardiography, I just say, "Arey, kya baas aa rahi hai na?" So patient just does that, and I can do that, because if you just ask the patient to sniff, they generally don't understand what they are supposed to do. Okay, so see, if I had measured this IVC at the RA-IVC junction, the collapse would have not been much, but whereas we measure it away from RA-IVC junction, we can see the collapse well. Okay, but friends, for this method, M mode is much better, because we can actually see the fullest diameter of IVC and the minimum diameter of IVC, which you need to find out better in M mode rather than 2D, because in 2D it depends on where we have frozen the picture, whether we took exactly in the inspiratory phase or not. So for that, in that we also see, we will see the pre-sniff, during sniff and post-sniff. See, like this, we should optimize the picture, and we can then get the collapse well. And then we have to see how much is the collapse. So what is the diameter and what is the collapse? Now earlier, friends, if you remember, this was the textbook picture. They measured to me things, the IVC, smaller IVC, that's less than 1.5, and near total collapse, the pressure was considered as 0 to 5, and so on. As the IVC diameter was more and more, and depending on the collapse, the pressure was estimated as 0 to 5, 5 to 10, 10 to 15, 15 to 20, and more than 20. However, this was improved upon in 2015 guidelines by American Society of Echocardiography, and this is what we use till present. They made it also simple. They have removed the ranges. They have given the absolute numbers 3, 8, and 15. What is 3? That is normal. That means IVC is less than 2.1 centimeter diameter, and collapse is more than 50. So this is normal. So pressure is then 3 millimeters. If both are not happening, that is IVC is dilated and collapse is less than 15%, then the pressure is considered to be 15. And if one of the two is right, that means either IVC diameter is normal but collapse is less, or IVC is dilated but collapse is good. For them, it is considered as 8. Okay, so that has been made very simple, easy to remember also. So in day-to-day practice, we can use it. Okay, we are looking at this IVC diameter and collapse. Can we use anything else? Because we expect that in chronic right atrial pressure increase, we also expect that RA will be dilated. So can we use that? So friends, that has been studied well. Looking at the RA volume, and not by 2D but 3D volume, is helpful, because in 2D, as we were discussing earlier also, like we take RV centric picture and then the RV size changes. Similarly, if you take RA centric picture, then the RA volume will be different. So in 3D, if you see, and that if volume is normally we see, and if there we see if that RV volume is increased, then that helps you as additional factor. So with all this, how accurate are we? If we use any one of these parameters, see, if we only use one parameter, IVC dilated, then okay, sensitivity will be increased because you are going to pick up more and more cases. However, specificity will drop, because RA can be dilated, IVC can be increased in size in some other conditions. Okay. If you take IVC diameter plus collapsibility index of more than 40% or less than 40%, then sensitivity of course will drop further, but specificity will increase. However, if you use all three, that is 3D RA volume of more than 35, IVC dilatation more than 2, and IVC collapse less than 40, then sensitivity will drop, but specificity will be very high. So if we use all three, our specificity is going to increase. Okay. So have we got excellent method, and therefore 3, 8, 15, is that good enough for all our patients? So there are limitations. For example, if there is pulmonary hypertension and torrential TR, free TR, RA pressure actually is going to be much more. But however, by our method which I described, maximum pressure of RA that we are going to calculate is as 15 only. So there we are going to go wrong. Similarly, there will be difficulties. It of course depends on the operator experience, etc. That to get good IVC. Similarly, sometimes, obese patients, it is difficult to get good IVCP image. And sometimes if there is suppose some stenosis at the junction of RA and IVC, then the RA pressures dynamics will not be reflected into IVC. Or if there is any mass in IVC, then of course we can't use this method at all. So even if you are seeing the IVC, we can't use it. So if we can't see and we can't assess the IVC size, what do you do? Now one, way which is suggested is then assume the pressure to be 8, RA pressure to be 8. Now this is not accurate at all. But error, like the margin of error will be reduced. By, it's like saying, is it mild, moderate or severe? When you say moderate, something is moderate. That means error will be there, but then it will be less. Another thing is, you look at some other findings and try to correlate with the RA pressure. For example, dilated right atrium, as we discussed. If right atrium is dilated, then of course, you have to look for higher RA pressure. And if the interatrial septum is bulging continuously into the left side throughout the cardiac cycle, that means RA pressure is likely to be high. But these are only qualitative. They don't tell you exactly what the RA pressure is. But then if you are getting these findings, then they tell you that you have to look for this at least and assess for the cause of right RA pressure. Now, can we use other veins? Okay, if I can't use, IVC because I am not seeing it well, can I use, say, internal jugular? Can I use femoral? Can I use subclavian? And are these studied at all? Yes. Friends, some articles are there available for that. Look at subclavian vein. Now, this particular paper, it studied sonographic evaluation of intravascular volume status with subclavian, and it compared with IVC collapse. And what did they find? That correlation is quite good. Okay, it is acceptable correlation looking at the subclavian vein collapse and IVC collapse. And they also found that this method may be sometimes quicker to get the subclavian vein by imaging, maybe even faster. Their numbers were 70 seconds versus IVC 99 seconds. So reasonable adjunct, but of course this does not replace looking at the IVC. Just to save time, you should actually try to get IVC, but if you had difficulty in getting IVC, you can use subclavian. How about internal jugular femoral? Now what has been found is, this particular article tells you about that correlations are weak. Why that happens is, internal jugular vein collapsibility index overestimates collapsibility, and the femoral vein underestimates the collapsibility. And therefore, they should not be used for measurements in routine practice. Again, those two veins could be imaged very quickly. Can hepatic vein help? And earlier we were talking about this hepatic vein. Now, in hepatic vein you get systolic VTI, diastolic VTI. Normally systolic should be more than diastolic. So if systolic is less than total VTI, that is systolic over systolic plus diastolic, if it is less than 55%, then RA pressure is going to be more than 8, like this. Now look at systolic VTI, diastolic VTI. So systolic upon sum of systolic and diastolic, if it is less than 55%, then it is going to be RA pressure of more than 8. Now here, this particular example, look at this. Systolic is 7.28, diastolic is 11.3. So together it becomes about 18.5. So systolic, that is 7.28, is less than 18.5. So that means in this particular pressure, RA pressure is more. Another one is taking right-sided E by E prime. That is taking, So taking tricuspid flow velocity and tricuspid annulus tissue Doppler imaging, their E by E prime, if it is more than 6, RA pressure is going to be more than 10. And one more method is by using tissue Doppler imaging is that by tissue Doppler imaging, if we find out that right ventricular regional isovolumic relaxation time, okay, so what is that? Right ventricular regional isovolumic relaxation time is after the systole. Systole has ended here and diastole begins here. That is, flow begins here. So this particular interval, if it is less than 59, then RA pressure is more than 8. That means the flow started earlier, so RA pressure is high. Now with all this also, with all our methods, there are some limitations. One limitation is in athletes. Now what is the limitation in athletes? Now it was also studied extensively. Friends, trained athletes have very frequently larger expiratory long axis diameter of IVC. That means IVCs are dilated in athletes even in absence of high RA pressure. And what is the reason? Reason is that their repeated intermittent volume loading, and therefore the IVC is dilated. So, but the collapsibility index will be normal, but IVC will be dilated. So by that IVC dilatation alone, you should not be diagnosing high RA pressure. What about the patients on ventilator? We know that normal inspiration is negative intrathoracic pressure, whereas patients on ventilator, there is positive thoracic pressure. And therefore, the IVC will be dilated and IVC will not collapse. And therefore, this is our usual method of looking at IVC is not going to help us. But we can then use some other methods like I was discussing. Right-sided E by E prime of more than 6 will give you RA pressure of more than 10. And of course, if the patient has a central line, because many of our patients with ventilator have central line, and then of course you can take central RA pressure directly. So friends, in short, measurements of RA pressure are helpful in determining fluid status in some patients, and most importantly for getting RV systolic pressure and therefore pulmonary artery systolic pressure in absence of pulmonary stenosis when there is TR. And of course, we are going to have a full talk on this by Dr. Prayakini soon after this. And IVC measurement and collapsibility index is a standard method. Correct methodology should be used, but we should always remember the limitations of this method from whatever I discussed. And of course, right heart catheterization is considered as gold standard. But for non-invasive assessment in our day-to-day clinical practice, this method is very, very useful. Thank you. Thank you very much.